We go on to our next talk, and that is Dr. Philippe Daudier, and it is alternative EC-IC bypass surgery for ischemic indications, history, indications, and current state of the art. We're excited to hear about your talk.
All right. Dear chairs, dear colleagues, first let me express my gratitude towards Professor Aliowski. Nuri, thank you very much for the invitation, for the excellent professional organization, of course, Nikolai. I've been tasked, quite a difficult task, to provide in this endovascular ischemic session the perspective from the neurosurgeon, but I come in peace. I'm dually trained, as you are, as Simone as well, and I'm going to try in the next 10 minutes to talk about our perspective for bypass surgery. These are my disclosures, I have no conflict of interest, and I'm going to talk about the history, just shortly and briefly, then about our standard in Vienna, and then about the outlook from our perspective. So just without going into too much detail, but as a French born, I have, of course, to go back to French history, and there wouldn't be bypass surgery without a specific event 130 years ago in France, the assassination of the president, François-Marie Carnot, who at the time was just basically stabbed, but could not be treated by lack of medical standards and medical training. It was a French medical student who picked up on this idea and developed the technology and the technique of suturing, and later on becoming also a Nobel Prize laureate for this. But the very first one that we should, especially as neurosurgeons, know would be Professor Yashagil, who in '67 in Zurich performed the very first STA MCA bypass. The primary indications in the first years indicates were the symptomatic ICA occlusions. Today, the established indications are the complex aneurysm treatments, meant as a flow replacement strategies, as well as the flow augmentation procedures for ischemia. This is what I'm going to talk about today. If you just look up in the literature for the STA and MCA bypass, you will see these two drops of numbers of publications, especially here in the 80s, and then just recently, more than 10 years ago, being due to these two publications, the EC-IC bypass trial and especially the COST trial, that changed the game completely from the neurosurgical perspective. Why? Because this prospective study, the best level 1 evidence we have so far, the best prospective study data, provided that the stroke rate for both the conservatively managed patients as well as the surgically treated patients were basically the same after 2 years. 23% versus 21% of ipsilateral recurrence of stroke on the same side. So this is the data we have been confronted with every single day, and still centers have been continuously performing those procedures as we've been doing in Vienna. And why? This is where I'm going to try to elaborate. The indications today from our point of view are that there's a subgroup, a very specifically defined subgroup of patients with misery perfusion syndromes that continuously experience TIAs on the best medical treatment, and especially improved medical imaging techniques of the recent, especially decade, has helped to select those patients that will and might benefit. So we have to document this critical hypoperfusion, especially by means of MRI and impaired CVR in nuclear medicine imaging. So our agreed indications are, again, I will repeat it and stress on this because it's very important. I'm not here to say that bypass is number 1 treatment, but it should be a recurring TIA management for best medical treatment, especially accepted for Moya-Moya disease, and of course as a bailout strategy in iatrogenic vessel injury. So this is the consensus as a last resort. Our standards is especially based on the imaging data, the MR perfusion, demonstrating this large mismatch, especially in the standard TTP measurements without the documentation of large strokes. We have then, of course, the HMPAO SPECT with and without diamox, demonstrating the reserve capacity. We perform the angiography to be sure, not only in a still image, in a CTA or MRI, but in the dynamic imaging, that the STA branches are not already connected to the cortical surfaces through natural anastomosis, and the CTA as a base for our self-developed planning tool. The bypass technique, I will spare you the details, but it has been the same for more than 30 years and hasn't changed significantly. We published recently our data where our self-developed software tool was used to pinpoint, to really identify both the donor vessels and the recipients ahead on a standard computer like this here, sparing time, being optimally prepared in the OR, and especially reducing the sizing of the craniotomy of the approach in the OR. And we demonstrated for the first time outside Japan the transdural ICG fluorescence of our target vessels before opening the dura, basically validating our tool. So in 95%, we could demonstrate an accurate recipient match. So what we planned before was also found during surgery, and had a satisfactory visualization in almost all cases through this transdural ICG. With a 91% overall bypass patency for those 50 cases that we published, and a good or excellent outcome, clinical outcome in a 79%. But the most important is, especially being confronted with the cost data and this very strong evidence, why are we keeping doing this? And this is our, let's say, of course, it's retrospective, it's not one-to-one comparable, but still, after 65 months long-term follow-up assessment, both clinically and radiologically, we had in our patients that received, in the 125 patients receiving bypass procedures for ischemic indications, 84% through the follow-up without experiencing any TIAs or strokes. But the ones that received, that had such a stroke, only 3 of them had an ipsilateral stroke, the ones that were basically assessed and documented by the cost data. So we're comparing, of course, our retrospective, again, I'm repeating this, our data of 2% ipsilateral stroke after 65 months compared to the 23% of the cost data that changed, again, completed the game more than 15 years ago. So we are still continuing to do this based on our in-house experiences, and the outlook looks positive, not only in Vienna, but especially also in Zurich. The Zurich group has been assessing in a prospective trial for the last years. We're expecting the data soon. How about the patients that you see and deem not appropriate for acute endovascular treatments, in stroke treatments? There's, again here, a very small subgroup of patients that might benefit from EC-IC bypass, and they have been assessed through a new medical technology, imaging techniques like the MRI-SL and the MRI BOLD techniques that can be used in a subacute setting and assess those patients with an impaired CVR. We are also using, since now 3 years, the ORBI device to perform bypasses. That is, from our point of view, especially from the ergonomic point of view, a huge benefit. And now for the last 5 years, we've been working together with Polimi de Milano and our Department of Medical Physics to develop for both endovascular and microsurgical techniques, vascular techniques, a simulator. Seems the video works, does it work? It is primarily been developed as a clipping simulator that is in-house printed, that has basically hyper-realistic vascular haptical features. There's less than 0.3 millimeters of vessel wall, and it is also perfused. And since this week, it just came yesterday evening from our latest workshop, in-house workshop, where we had 32 hours of assessment of the next generation of bypass simulator based on this technology. And especially this on the right side is a very, let's say, dear topic of ours. We are trying to be as objective as possible to objectify the skills of our participants. And we also developed a dexterity measurement smartwatch application that measures the skills over time during the entire course of your participants, and that demonstrate that the confidence, the level of confidence is rising with every single suture and also clip performance you do. So to conclude, again, I will repeat it because this is such a controversial topic. We have the agreed indications from our point of view for recurring TIAs on the best medical treatment, Moyamoya disease, Rayleigh syndrome, and the iatrogenic vessel injury. And with this, I'm thanking you for your attention.
Wonderful. Thank you. The software for the flow augmentation surgery, is it, CE, you said you did the validation studies.
Only in the research.
Is it CE marked?
No.
No, is it
No.
Going to be a class 1 device, or it's
No,
probably
it's not
a
going
class
to be.
2? Because
Until
it
now, it
measures-
has not been used outside our center. It's only used for research purposes, and therefore, for now, unfortunately, there are no ongoing discussions to market it.
Very interesting. Any questions from the audience?
One question related to the Moya Moya. Are you using direct bypasses also for Moya Moya patients, or are you using also non-direct? So,
for adult patients, we are doing it after assessment of the DSA, of course, because in those cases, if you have a level Suzuki stage 3, 4, 5, 6 patients, they've already collateralized anastomosis, natural anastomosis. It's once you do not take care of them, you're going to stroke your patient just by performing the skin incision. And for the children, we do the EDS and the burr holes until now. So we're looking forward for the robotics to change that, to get one dimension deeper into weights that the imaging technology will also improve to go towards the infants and the children patients.
Thank you.